Good morning, I'm Dr. Shona Edmonds. I'm a pediatric surgeon. I'm based in Selangor, Malaysia, and I trained as a pediatric surgeon at the University of Malaya and in Ministry of Health hospitals here in Malaysia. I thank you for the opportunity given to me today to be able to share some thoughts on management of Empyema Thoracis in children. The gist of my talk would first include a definition of the stages of Empyema Thoracis. This is an internationally accepted definition. And following that, I'll be talking about the surgeon's role really in the form of decision for imaging prior to surgery, decision for when we should do surgery, and the type of surgery that should be done. Empyema Thoracis is a condition where the pleural cavity is filled with pus, right? Now, most commonly it is due to a pneumonia, right, in children. However, there are more rare causes of Empyema Thoracis. It might be due to esophageal perforations or even thoracic trauma or thoracic surgery, following thoracic surgery. But the commonest would be still secondary to a pneumonia, community-acquired pneumonia. I believe the place where I practice here in my country, Malaysia, is very similar to most Southeast Asian countries, as well as in India, right? And so a lot of my papers, my reviews will be coming from this part of the world rather than from Western literature. The common organisms, as I mentioned, from community-acquired pneumonias would be the Streptococcus species, Streptococcus pyogenes or Streptococcus aeruginosa, followed by Staphylococcus aureus. Less commonly, we have Haemophilus influenza, Salmonella species, and in a non-resolving empyema, it'll be very important for us to keep in mind tuberculosis. Now, what are the stages of parapneumonic effusion? I am taking my definitions from the Pediatric Protocol for Malaysia booklet. This is really our go-to book here in my country when we deal with children. And this is our 2019 print, our 4th edition really. So I'll be taking guidelines from this protocol, and this is actually a standardized protocol recommended for public hospitals throughout my country, right? Now the stages of parapneumonic effusion as defined globally would be stage 1, the exudative phase. This tends to happen between 24 to 72 hours from the onset of a pneumonia, right? Now the exudative phase, typically the pleural fluid is still very clear. It's a clear exudative fluid, and the patient has signs of systemic infection such as fever and cough, and there is some pleuritis. Now, given the fact that this is a very short window period for this phase to occur, most of the time this phase settles together with antibiotics, that is because of the antibiotics that is given for pneumonia. So the surgeons don't get to see this part of this phase. We're not really involved in the management of patients at this stage, right? The pediatricians are the gatekeepers in this situation, as all children who have a lower respiratory tract infection end up with pediatricians. And so they really are the gatekeepers to the following stages of a parapneumonic effusion. So by 24 to 72 hours, most stage 1s would resolve together with the underlying parenchymal inflammation. It is the stage 2 and the stage 3 part of the disease where surgeons then become more important in management. So this stage, we have the fibrino purulent stage, stage 2. And this typically occurs within the first week to 10 days from the onset of parenchymal inflammation or the pneumonia, right? Usually for pediatricians, if a child's fever does not seem to be abating by day 5 to day 7 of illness, they would have ordered a chest x-ray or even an ultrasound to start considering if they are dealing with a parapneumonic effusion at this particular stage. So how does this stage actually look like? Now, at this point of time, the pleural cavity is pus-filled, right? It's not a clear exudative effusion anymore. The pleural space becomes pus-filled filled with pus-filled fluid, right? There's also the development of fibrin clots or membranes, which create septations or loculations within the pleural space. And thoracoscopically, this is what it would look like at this stage. If you notice, this is the superior part here is the parietal pleura, the rib cage. On the inferior part, we have pink lung tissue down here, and in between we have septations of fibrin clots or bands, and they form loculations within the pleural cavity or the pleural space. You notice that it's very thin and very friable. On an ultrasound, this would look like cobwebs on a black background. Right? Very easy for the radiologist to recognize this with an ultrasound, right? And this septation phase, these septations are very easy for us as surgeons to remove, even especially laparoscopically, because they're very thinned out. We give a good wash to the pleural cavity and we're done. We come to the third and final phase, which is the organizing phase. And this phase takes place about 2 to 4 weeks from the onset of pneumonia, right? So at this stage, the lung is then encased with what we call a pleural peel. It's a thickened, non-elastic encasement of the lung. And this is formed by fibroblasts, which has grown over the parietal and pleural surface of the lung. And it looks very much like this. So again, the superior part here is the parietal pleura of the thoracic chest wall or the thoracic cavity, and inferiorly we see a glimpse of normal lung tissue here, which has some layer of fibrin on it. But on the left side of your screen, you find that this part here is so thickened it looks literally like coconut, the white of the coconut. When you actually cut a coconut open, right? So this looks like the white of a coconut. There's an obliteration of the pleural space, and you find that the lung is very tight because it's encased by this whole thick peel. So this is the organizing phase, organizational phase of Empyema thoracis. Right. Now, this is just part of a flow chart that I wanted to share here with you from our pediatric protocol guideline. Now, as mentioned, the pediatricians are the gatekeepers. They would have initiated medical therapy once they realize that they're dealing with both a pneumonia with a parapneumonic effusion by starting antimicrobials, antibiotics. They may have put in a chest drain by stage 2. If it was recognized, stage 2, they usually put in a chest drain. We have supportive therapy with oxygen and fluids, and they would also consider intrapleural fibrinolytic therapy at stage 2 level, which is usually streptokinase. Okay. Now, the reason I put this up is because the surgeons are only called in at this point where there's either failed medical therapy, i.e., where streptokinase has been attempted, but the patient has not shown improvement, or there has been no radiological improvement to the lung, to the thoracic cavity, or if the patient comes in at the stage 3 level where streptokinase should not be considered at that point. So surgeons are usually called in at a much later stage, and it's the same world over. Even in based on Western literature, surgeons usually are involved much later in the game, all right? However, guidelines are there to assist all range of doctors at all levels in different parts of our country, which has variable demographics. So it's a good guideline to have for any pediatrician or pediatric doctors who deal with children in different parts of the country. However, in a center where there are surgeons who can do this, I would now like to suggest that the surgeon's role should actually start very much early on in terms of discussion of where management of this patient will be heading to, right? And not just involve us at the very tail end of the management. I'd like to present a very elegant paper from Chandigarh, India, northern state of India. And this was actually published in the Journal of Tropical Pediatrics in 2019. This paper really looks at what has changed in pediatric empyema thoracis over a period of 10 years. So it's a very nice paper to look at comparisons of the disease 10 years before this paper was actually written, okay, because it gives all of us here in Southeast Asia a kind of a similar feel of what's been changing in our part of the world as well, right? So this is just a comparison. So the current study is based on a period of 5 years, from 2007 to 2011. It has a number of 205 patients. They compared it to an earlier study that looked at, from India itself, that took an account of 10 years, okay, from 1989 to 1998, with a similar and almost similar number of patients of 243. So we're really comparing apples for apples here. And this paper really looked at a wide variety of from demographics as well as in type of infectivity and surgical procedures that were done, right? Now, looking at this, it was significant that methicillin-sensitive organisms were more predominant in the earlier years. There was there was a significant p-value here, whereas the MRSA started cropping up in the more recent study, right? So we're dealing with more MRSAs at this point of time, right? In terms of organisms. Also, streptokinase was not mentioned in the earlier paper. Obviously, it is a more recent form of treatment, and it was started somewhere in the mid-2000s, which is when this paper was when this paper was started to be compiled, right? And in terms of surgery, there was more surgery done more recently. So we're looking at more surgical interventions moving forward as compared to more of just antibiotics or prolonged antibiotics in the years past. The other thing to note was that there was a higher mortality rate in the more recent study, right? Not very sure how to explain that, but I thought that it would be interesting to highlight these significant changes from 10 years before and looking at it forward, right? Which is where we are. Now, what is important in this paper, essentially that I wanted to share with you, is that the numbers who underwent surgical decortication or needed surgery is roughly 1/3 of the total number of patients that were managed. All right, this is significant because it means that for the surgeons, we can expect 1/3 of patients who develop a parapneumonic effusion to be sent to us. Significant number, right? Moving on. Whenever I am referred a child with an Empyema thoracis, in my practice, I always ask myself two important questions. Okay, the first is, what imaging modality should this child have before surgery, right? And the second question is, what is my choice of surgery for this child? And each child becomes an individualized case, right? No two children are the same. And so I keep these thoughts in my mind as I approach my patients. Now, let's answer the first question. Imaging modality before surgery. For any surgeon, imaging is vital as a roadmap. So it gives us an aerial view of the rough terrain that we have to sort of conquer. It gives us an idea of the anatomy that we are faced with, right? No surgeon would like to operate blind, right? Then we need to prepare, right? So it gives us a good roadmap. Especially in such a hostile condition, we really need all the roadmaps that we can to get the child safely from A to E, right? Now, with Empyema thoracis, there's truly no guidelines on imaging anywhere, right? The guidelines are adopted by the surgeon, the operating surgeon, or the institution that they belong to, right? For this point of time. And in preparing for this talk, this is what I recognize is inadequate at this point of time. Okay, which is why I, as a surgeon, need to know what is the basis of what I'm doing. So I'd like to share this study that was published in the journal or in the British Medical Journals back in May 2008. So it's some time ago, but it's a nice paper to read because this comes from Great Ormond Street Children's Hospital in the UK, and it looked at the role of routine CT scans in pediatric pleural empyemas, right? And its conclusion was interesting. It basically stated that CT scans do detect more parenchymal abnormalities than chest radiographs, naturally, right? However, it does not alter the management of a patient with Empyema Thoracis, and it is unable to predict its clinical outcome. Interesting. So there is no role for the routine use of CT scans in children with this condition, right? For those of us who work with children, we are always conscious about ionizing radiation from a very early age. We are taught, and it's ingrained in us, that as far as possible, reduce the incidence of ionizing radiation. And we know that CT scans carry a far higher amount of ionizing radiation in children, in childhood, right? So the question that we always have to ask ourselves would be, is this choice of study important, or will it help improve the outcome of my patient if I were to do it? And so this study basically has proven that there's no role for its routine use, right, in Empyema Thoracis. However, I would like to share with you two cases of interest that was managed together by myself and with the pediatric respiratory consultant in my center to show you the importance of when this rule has to be broken, all right? Now, just to share with you, this is a 1-year-old girl who presented with a cough for 2 weeks of duration, and this was associated with fever and tachypnea for 3 days. Now, based on the history, most of us would think this is a straightforward pneumonia that was neglected and is now a full-blown empyema, right? With a cough of 2 weeks, most of us would think, okay, she's probably in a stage 2 to stage 3 empyema. So if you look at the chest x-ray, it's a complete whiteout of the lung with a mediastinal shift to the right. So from the chest x-ray, we move on to an ultrasound. This is the standard management of imaging in Empyema Thoracis. The radiologist was able to demonstrate that this is the lower zone of the hemithorax, of the left hemithorax. We find that there is a thick peel, okay, a very thick peel at the top, heterogeneous fluid, and there looks like what may be a very thick septa jutting out here, all right? However, the radiologist pointed out to the clinicians that in the upper zone, there was a mass that looked that was heterogeneous, did not conform to a typical empyema in the upper lobe. So once there is a doubt of if the imaging actually conforms to that of a typical empyema, then we should be more cautious and request for a CT scan before any form of procedures are undertaken. And so that's what we did. We decided to then move on with the CT scan before any ultrasound, before any chest drain was put in, before even any antibiotics were started for that matter. And lo and behold, this is what the CT scan showed us. It showed us a large multicystic mass, all right, a heterogeneous multicystic mass involving the entire left hemithorax in this child, which was pushing the mediastinum to the right. Okay, if you notice the image on the left here, this bright image here shows Ostra units that are similar to the bone. So this is actually a bone or a calcification rather within this mass. And so the diagnosis of a thoracic tumor, which was likely a teratoma, was made. The child, we performed surgery on the child, and the histopathology came back as a benign mature teratoma with focal inflammation. Now, the histopathology specimen images here don't do justice to what we just saw before, because this was involving the entire hemithorax, but bear in mind, there were a lot of cystic fluid-filled spaces, of which the fluid was removed from the histopathological specimen. And this is the solid part of the tumor that we see. Okay, so in this situation, when there is a doubt in the ultrasound images by the radiologist, this should alert the clinician that we should break with norms and go on to do a CT scan. All right, number one. This is a 12-year-old boy who presents with a cough, a low-grade fever for 2 weeks, and he presented to our emergency department with worsening dyspnea for 2 days. So this boy was previously well. However, within a span of 2 weeks, he developed symptoms very much similar to what most of us would consider as maybe a stage 2, stage 3 empyema by now. Again, a complete lung whiteout, air bronchograms seen towards the right side of the chest, and the mediastinum shifted as the previous case. Moving on to an ultrasound. Yes, the radiologist was able to find fluid-filled pleural space. However, she also noticed a lower anterior chest wall mass. So again, we were alerted to this matter. As soon as the imaging does not conform to a typical empyema image, we should already be having alarm bells. And again, a CT scan then confirmed that this child did have a massive left pleural effusion, the one that I'm pointing to on the right side of the screen. But in the lower zone of his left hemithorax, we find a mass, right, arising from his chest wall. So the diagnosis of an anterior thoracic wall tumor with massive pleural effusion was made. And just to bear in mind, this boy has an adult stature. He's 70 kgs. And the reason I tell you this is because even in a big built child, the role of imaging is still ultrasounds and x-rays first, and not a CT scan, even if the suspicion of an empyema was made. However, we had to break with that norm again because of the discovery of a mass. We then performed a pigtail drain because we wanted to relieve the effusion on the left under ultrasound guidance, and the biopsy of the tumor was done during the same sitting. Lo and behold, it was confirmed to be a rhabdomyosarcoma of the anterior chest wall. The child is still undergoing chemotherapy for this, and definitive surgery will be done soon. So basically, the reason I share these cases of interest with all of you is to imply that we need to break with the norm when there is a suspicion of something more sinister than just an empyema thoracis in the child. Okay. Now, moving on. The second question that I asked myself would be, what will be the best choice of surgery for this particular child at this particular time, at this particular stage of the disease? Would it be a minimally invasive technique, or should I consider an open surgery? And I'm not here to debate the pros and cons of both. I was, as all surgeons ought to be, I was trained in an era of open surgery and then gradually moved into minimally invasive. And so I'm very selective about the kind of cases that I choose to do videoscopic assisted thoracotomies for, okay, decortications for rather. Okay, so there are certain limitations with VATS decortications. It would have to depend on the stage of the disease that the child presents at and the surgeon's proficiency or experience. All of us have a learning curve, and all of us, since we train with an open surgery, in open surgery, that should be our backup in case things go very wrong in a minimally invasive form, right? Now, we also have to consider important decisions that have to be made intraoperatively while dealing with both minimally invasive and open techniques. Now, in minimally invasive techniques with VATS, we have to be very cautious once bleeding occurs, because with our cameras, once bleeding starts becoming more profuse, we only have a short window period to be able to secure hemostasis. So principles of decortication in empyema thoracis would be, firstly, complete removal of fibrin clots and septations. Secondly, to ensure that the lung is fully expanded. Thirdly, securing hemostasis. And thirdly and fourthly, ensuring that there are no air leaks before closing up the thorax. So these are the 4 principles, right? Imagine doing this with minimally invasive techniques and finding that we get caught with massive bleeding. The decision to then plod on would be very disastrous in a very young or small child because of the capacity to compensate in terms of blood loss and airway issues. So we have to make a very quick decision to remove our instruments and to convert this into an open surgery, all right? So these are the skills that I have been made aware of in my period of managing patients with such conditions intraoperatively. Now, a very wise professor of surgery of mine during my years in training here in University Malaya, Professor Tambidure, once made this statement, which I hold on to very dearly. Minimally invasive techniques are but an extension of a surgeon's armamentarium. And I've held on to this every time I perform anything minimally invasive, whether it's laparoscopy or thoracoscopic work, simply because it is but an extension. It is part of our armor. It should not be our main suit of armor, right? We should be proficient in both open technique as well as in laparoscopic technique, if that's our thrust. And I say this with caution because I do understand that there are probably many colleagues out there, many surgeons out there who are very pro, obviously, laparoscopy, and it's a good thing to have. It's a good skill to have. But we must always remember that it is not the ultimate skill to have. The ultimate skill to have is still the ability to quickly decide when either technique is not benefiting the patient and what we should do from there, right? So I keep this always at the back of my mind when I perform minimally invasive surgery. This is the final journal that I would like to share with you. This is taken from the journal of International Journal of Respiratory Pulmonary Medicine, which was published in 2020. This is a paper that was written by Malaysian surgeons here at the Department of Cardiothoracic Surgery in a hospital north of Malaysia in the beautiful island of Penang, right? They deal with patients, with pediatric patients with Empyema Thoracis. They looked at the roles and the outcomes of surgical intervention in advanced disease, right? So this is a fairly recent publication, and it echoes my sentiments as a pediatric surgeon who deals with similar cases, right? Now, based on their conclusions, their recommendations, they found that early surgical referral is much better in terms of its outcome when it comes to decortication. So they are recommending that patients be referred early to the surgeons at stage 2 rather than at stage 3, all right, as traditionally done. And they've got some papers to also back this finding. A paper from the Turkish group showed a quicker resolution of symptoms when patients are referred to the surgeons at an earlier stage for decortication, i.e. stage 2. Another paper from Ireland also shows a shift towards early referrals for surgery and better outcomes in terms of symptoms. So actually the surgeons are really requesting here, please refer to us at an earlier stage to improve the patient's outcome rather than in a later stage, right? They also spoke about minimally invasive versus open thoracotomy. And in their center, yes, VATS is definitely superior in the removal and visualization of pus because we are able to visualize the entire hemithorax better thoracoscopically. So yes, it is superior in pus removal. It reduces the duration of chest tube usage. There's obviously less pain, and it translates to an earlier discharge and better cosmesis. However, the debate with open thoracotomy they found was that thoracotomy was definitely superior in the removal of a peel. And I told you that the peel is something that we find in stage 3. It's as thick as the white of a coconut. It does improve there's significant improvement when we do this using an open technique, and we find that lung expansion is better compared to a thoracoscopic technique. Also, an open thoracotomy has superior outcomes in the later stage, obviously in stage 3, especially when it comes to improving adhesiolysis and controlling bleeding. And therefore, this team is actually recommending what we call a limited thoracotomy. So instead of a conventional large or long thoracotomy scar, this team actually has now managed to use a 3 to 4 centimeter thoracotomy wound in a small child. And I echo the same sentiments, because when I start with VATS in a patient and I find that I'm struggling, especially in a stage 3 empyema, I've already had a good visualization of the field internally. So I remove my camera and I'm then able to focus my incision to where I find the most thickness, and therefore limit my thoracotomy wound size. Right, so a limited thoracotomy is what this team is talking about in children, right? So while VATS would be ideal for an earlier stage of empyema like the stage 2, we have to consider that while there's no right and wrong of using VATS in a stage 3 empyema, it certainly does not mean that we should not be quick to convert if we feel that that would benefit the patient in the long run, okay? Take-home message for us here today would be, firstly, a close working relationship between the pediatrician and surgeon in making decisions together for the benefit of the patient, instead of in silos. So ideally, the pediatrician ought to get the surgeon involved at a very early stage, even at the stage where intrapleural streptokinase is considered, right? So it gives the surgeon a kind of idea as to if the child is going to improve or not improve with this, and if the child doesn't, let's consider now when surgery needs to be done rather than prolonging the time with streptokinase, right? So the important working relationships in these sort of decision makings ought to be happening. Secondly, in terms of imaging, a chest X-ray and ultrasound is sufficient for the diagnosis of empyema thoracis. However, as I showed you earlier, a CT thorax is indicated in unusual ultrasound findings. And lastly, the choice of surgery is really dependent on both the clinical condition of the patient. You wouldn't want to be taking a long time in a child who is very septic, very sick, who's on inotropic support. We want to do something quick and concise, and therefore it is based on the surgeon's experience and preference in the matter. Okay, and thank you for your time in following this message. Thank you.